Good morning from New Jersey. Hey, I see a bunch of people are watching. This is Dr. Nick Tullo with the ECG Academy, and here we are. Now I'm doing something different this time. I actually I clicked a setting on YouTube for ultra short latency. So maybe if you guys post a question or a comment or answer one of my queries, I'll see it much quicker. Wow, look at all these people from Houston and Tacoma. Thanks. Blue Mermaid's there, Larry McCarter, Brian Gomez. Thanks so much for joining me. This is going to be fun because, it's clinical, but this is a topic that we don't talk about too much except in the classroom, and seeing and getting some practical information about antiarrhythmic drugs, I think, is really important because you guys are out there and you're seeing arrhythmias and you're taking care of patients, and sometimes you're not sure which drug to pick. So I thought I would give you my insight as a cardiac electrophysiologist and help you figure out, where to go with drugs. Now, it's Saturday morning in New Jersey, and I must say this is, hey, Jess Winder from Indianapolis, fantastic. Afsal from Australia, good day, mate. So anyway, in New Jersey, today is like the first day that I can remember in the last 5 months that I could actually go outside without a coat. So the dog is walked and fed, and everyone else is asleep upstairs. So, here I am. Welcome. Thanks. Oh, hello, Richard from London. So good of you to join me. And speaking of London, I've got my TARDIS on my shirt here. Look, keep calm. I'm the doctor. I don't know how many of you guys watch Doctor Who, but it's a favorite in my family, and it's great. So since the weather was good enough to wear a t-shirt in the home, I'm good with the doctor. All right then. Manchester, Massachusetts. Hello, Janet. Oh, we've got a big crowd today because, I sent out 1 million emails last night, and I hope these things are catching on. So please share it with your friends if you enjoy this content. Remember, there's a link in the description below where you can subscribe to ECG Doc and get notification when I'm going live. Most Saturdays, I would say, I'm going live. But you can still see I'm surrounded by mess. This is my icky upstairs office, but I want to share something with you. Here's a picture of my recording studio. Now, we did a big renovation on the house rather than move to a bigger house. And when we dug out the foundation for the new kitchen, I created my little brand new recording studio down here. So here's what it looks like. Ooh, isn't that cool? The Navajo Reservation. Matilda, thanks so much for joining. But take a look at my little recording studio here. So the equipment's not all in there, but the furniture's in, the monitors are in, and I'm just going to set it up so that it's good to go whenever I feel like live streaming. Yeah, my son keeps telling me, "Oh, just go live, Dad, anytime, whoever's watching." But it's really nice to be able to interact with all these people. Thanks. Thanks, Paramveer. I'm glad you like it. It's really kind of cool. But this is furniture that I had made probably 20 years ago, and I've been bringing it from one house to another. It's, I'd moved down to Chattanooga for 3 years. I was with the Chattanooga Heart Institute and doing EP there. But when I moved back to New Jersey, I was like, how do I use my AV skills and my arrhythmia skills? And that's how I got started with ECG Academy. So it's funny because on a Friday, people are always asking me, "Hey, what are you doing this weekend?" And I don't usually say anything because here I'm usually either doing this or answering emails. It's a lot of time that I spend on weekends kind of handling things. But work has been getting kind of busy since my partner left. Uncle Paul, you told me you're watching, so I just want to shout out to you, you dirty rat, you left me high and dry, and you know who you are. So anyway, let's get to this presentation. It's actually sort of a generic. I'm not going to give you like a whole bunch of history, but I wanted you guys to see what I see. And when I went on to the floor and I was looking around at some monitor strips, I happened to notice this, and I think it's was really cool. So here are the Jay Shree. Thanks for joining. Thanks, Blue Mermaid. It's gonna be great once it's all finished, that recording studio. So here is the strip that I saw on the monitor, and the nurses were getting all concerned because the patient was having salvos of wide complex tachycardias. Now, some weeks back, maybe a couple of months ago, I did one of these live streams and I talked about wide QRS tachycardia as being a term that you should try to avoid, because it doesn't tell you what it is. It simply describes what you're seeing, but you really need to try to figure out whether it's VTach or some sort of atrial arrhythmia with aberrant conduction. I mean, that's sometimes one of the hardest things to figure out if you're not tuned into the physiology and how things work, and if you're not used to looking at fine details. In my online course, ECG Academy, I show you how to look for those fine details, but that's what we're here this morning to kind of talk about. So when you look at the entire strip, and let me make sure I have the right tools here. So, you know, when we do these live, it's just like, let me see, artistry brush, no. I want a pencil tool. Here's a brush tool. Okay, oops, kind of big. So let's see if I can write on this now. Sorry for the, I should be more prepared, but you know, I get up early on a Saturday scanning things for you guys. So if I'm a little disoriented or disjointed, so let's see. All right, so oops, let me increase my opacity. If you guys, last year I went to Photoshop World, and that was a great conference. If you're into photography, definitely go. So here is the strip that I saw, and what I see is a bunch of wide complex QRSs here, you know, FLBs as I like to call them, funny looking beats, and here's a run of 4. But what is what the atrium doing, and what is the ventricle doing? And when you look at the other beats, the smaller beats, you can actually see that there are P waves in front of these beats. Sometimes the PR is really pretty short, actually. This one looks very short. It almost looks like a low atrial beat. And, you know, if you look at this P wave, it almost looks inverted. So the PR is relatively short, but all of these beats seem to have P waves in front of them, except it's very irregular, isn't it? I mean, you've got long intervals here, but then you've got shorter ones here, and then you've got very short ones here. And the thing to do is when you see a wide complex beat, you have to decide, is this aberrantly conducted? Now, what is aberrancy? That's what I talk about in past talks of these clinical live streams and in my course, which you remember is aberrant conduction is when the two bundles branches don't depolarize at the same time, or a part of the interventricular conduction system is delayed. Why? Because of refractoriness, because it hasn't recovered from the previous beat. So aberrant conduction is often rate related. So when you have a short interval and the signal comes down from the AV node and hits that conduction system at, I'm just making sure that everything's streaming right, and hits the conduction system at a point where part of the conduction system is not able to accept the beat because it's refractory, that's when aberrant conduction occurs, because then part of the conduction system depolarizes and the rest of it has to kind of like make its way up the back door. So rate is important. That's why I always say, if you know, in my last clinical live stream that we talked about that, if you are in a normal rhythm here and then you have a wide beat way out here where there's no prematurity when it's very late, then that's almost always ventricular, because aberrant conduction has to be premature. But when we look at these beats, they are premature. In fact, the wide beats always seem to be universally coupled with a pretty short interval. Look at that. They're all sort of premature. They're all kind of like R on T, if you want to call it that. So it's possible that they are aberrantly conducted atrial premature beats. The only time that the point is that they have to be, if you're going to think, if they're premature, they may be aberrant. If they're not premature, then they're almost certainly ventricular in origin. That's what I was drawing down here. So if it's really late and it's wide and bizarre looking, it's almost always a ventricular beat or VTAC or something. But here we have them, they're very early. So then the next question is there a P wave in front of the beat? And the way to figure that out is to look at all the T waves and try to find try to see if there's a P wave superimposed on the prior T. So get an idea of what the T wave looks like. Here you have this T, which is relatively flat. This T is relatively flat. And when you look here, you see that there is a bump right there that looks much higher than this one here. So that's a PAC, isn't it? So if you didn't look for that little tiny bump in front of this wide beat, you might assume that these were ventricular. But if you look at every single one of these wide beats, there looks like there's a PAC in front of it, including this one here. If you look at this T wave, it's very flat. And when you look at this sweet T wave, it's got a big pimple on top of it. Okay, I was watching Pimple Popper, Dr. Pimple Popper. Anybody see that? Oh my God. This is this very energetic Asian dermatologist who has these really viciously disgusting YouTube videos of, well, these cysts and, anyway. I'm sure that, all of you, good morning, Jolly. Glad you could make it. That's fine. Anyway, so yes, there's a pimple on top of that, but please don't pop it. Thank you. So that is a PAC. And so it would appear that all of these runs are aberrantly conducted atrial beats, because if the first one is wide and all the rest look the same, then it's almost certainly an atrial arrhythmia. So you can even see here, there's a little bump on the T wave, and that's the P that's responsible for this beat. Now, you don't have to find a P wave in front of every beat. I mean, you have to kind of like call it as you see it, because it's extremely rare for someone to have like an aberrantly conducted PAC followed by a run of VTAC. I mean, 99% of the time when you see a run like this, it's going to be a run of atrial tachycardia that's conducting aberrantly. Okay, so it's pretty easy to pick that out, but it gets worse. Here was a run over here, and this is where the nurses were getting, very concerned, because you had a very long, 8 or 9 beat run of this same stuff, but it looks the same as the other strip, doesn't it? So if it looks the same, it's probably the same, right? And sure enough, when you look in front of this first beat here, you see a PAC, and it occurs at a pretty fast rate. This is about 150 beats per minute from one PAC to another. So the interventricular conduction system couldn't handle it, and part of it was refractory, and so it went off and running. Now, there's just as an aside, I'm thinking, okay, people might look at this and say, oh, but maybe there's AV dissociation, because here this looks flat, but here there looks like there's like a bump there, and could that be a dissociated P wave? Well, I don't think it's dissociated. I think these are the P waves that are conducting to the following QRS complex. Here's a bump here that conducts, here's a bump here that conducts, then you have one here, and then now here you don't see a bump, and you might say, oh, look at that, it's dissociated. But this T wave looks a lot taller, and if you notice that this interval is a lot longer, relatively speaking. So I think this atrial event in this run of atrial tachycardia just came late, and it came on top of the T wave, which made this T wave tall compared with this one. So that's a P wave, and that's the last P wave of this run of tachycardia, and then the patient's back in sinus rhythm. The fact is the AV node seems to be very, very healthy in this patient. So whatever happens in the atrium, it's being transmitted down the AV node very quickly, and it's the interventricular conduction system, the bundle branches, that have the problem. But in reality, it's only a relative problem. It's a cosmetic issue. It's only happening when the heart rate goes above 150. But what happens when the patient is continuously at 150? So I looked further and I looked back and I saw on the trend, there was this period of time when the patient's heart rate went on for about 15 minutes or so, where it was very, very fast. And this is what I found. And this is one example of how wide, irregularly irregular rhythm is indeed atrial fibrillation with aberrant conduction. Although maybe not. I mean, maybe you can see discrete P waves here and there, and maybe there is, some atrial tachycardia that's conducting with some second degree AV block. But certainly this is a rapid continuous atrial arrhythmia, whether it's atrial tach or atrial fib. I think it could be even an atypical atrial flutter, but regardless, all the beats are conducting aberrantly now, because now the AV node is just pelting this conduction system with rapid beats, and that's why you have this continuous wide complex beat. And but then this broke, and then you were back to narrow and wide and narrow and wide. So all right, when you look at this and you say, okay, well, I want to pick a drug, I want to try to treat this, whether the patient is good morning, Gail from North Carolina. As I said, I was working in Chattanooga, Tennessee for about 3 years, and I come to appreciate living in the South. It was a wonderful community, but North Carolina's, I know a lot of people who live down there, and they love it. Anyway, what drug would you pick? The patient, let's say, is having palpitations. Whether they're having palpitations or not, I mean, this is the discussion. Certainly if you're having little bursts of atrial arrhythmias and the patient's not symptomatic, it may be an option to not treat it, but now you're having continuous arrhythmias and going on for a long time. So what's the first question you want to ask? Really, what is and it's not about symptoms. I mean, when you're going to pick a drug, there's one piece of information that's really, really important. And that's the left ventricular function. What is the ejection fraction? What's the patient's history? Do they have coronary disease? Do they have LV dysfunction? Is there a scar on the heart? Because that limits which antiarrhythmic drugs you might want to select. And the reason is that certain classes of antiarrhythmic drugs can be pro-arrhythmic. They can actually make arrhythmias worse, and you don't want to pick those. We'll talk about each one of the classes individually in a minute. So at any rate, let's start to talk about the antiarrhythmic classes so that we kind of are all on the same page. So we're going to get rid of the picture of my studio, and we're going to talk a little bit about this. So you can see I did my homework a little bit. So, the Vaughan Williams classification scheme was published, I think, in the 1960s, and it sort of classified each antiarrhythmic drug in, let me just be able to draw on this, in a different class, a class 1, 2, 3, and 4. So we'll go over these just to kind of remind you of where the pharmacology is and how you should be thinking. And it all has to do with the way they behave electrocardiographically and what ion channels they affect and how do they affect the action potential in particular. So here is a drawing of the cardiac action potential. Phase 0, remember, is rapid sodium rushing into the cell, making the inside of the cell more positive. And then you have a plateau phase where sodium and potassium are both sort of moving, and calcium is moving into the cell in order to activate the actin and myosin fibers. And it gets very complicated, and I'm not here to tell you all about the cardiac action potential and the ion channels and what happens during the cardiac cycle, I do cover some of this in the basic course, and you can actually sign up for a free membership on ECGacademy.com. The free introductory membership includes all these ion channels, but in the advanced class in the advanced level, you can access a lecture that I did on inherited channelopathies. So things like long QT syndrome and Brugada and so forth. And I talk a lot more about calcium movement in and out of the cells and in and out of the sarcoplasmic reticulum. But this is going to take hours if I go into it today. So anyway, here's your plateau phase where calcium is moving in, this sodium and potassium are sort of moving in equal portions, and then repolarization occurs when potassium rushes out of the cell and restores the resting membrane potential. So when you talk about class 1A, class 1B, 1C, class 1, 2, 3, 4, it all has to do with which channels are affected. And generally class 1 predominantly affect sodium channels. So that means they affect depolarization. They reduce depolarization because they block the sodium channels, so the slope of phase 0 is diminished. So the slope of phase 0 is decreased. And what is it about the action potential rapidity of depolarization that's actually proportional to the conduction velocity through the tissues? So when you depress phase 0 and you slow the action potential upstroke, that affects conduction. That affects how quickly cells pass the signal from cell to cell to cell. So it affects conduction velocity. And that's what class 1 sodium channel blockers all do. They slow conduction through the heart muscle. Okay? Now, the difference is between 1A, 1B, 1C is that 1A also happens to block sodium channels. So you see, just because, think of these ion channels as being proteins embedded in the cell membrane, and they're sort of like have this three-dimensional shape, and the drug comes along and interacts with it, but it won't just interact with the sodium channel, it may also partially block some potassium channels, and that's what the class 1As do. They block sodium and potassium. So when you block potassium channels, what do you think happens to phase 3? It becomes delayed. So quinidine, procanamide, and disopyramide all suppress phase 0, so they all slow the conduction down. And what does that do to your QRS complex? Instead of being very sharp and very narrow, it causes the QRS to widen because it's taking longer to get around the heart. Plus, they delay repolarization, and so what happens to your QT interval? It gets longer. Okay? So, class 1A agents all delay conduction, and they also prolong repolarization. So you get widening of the QRS and you get prolongation of the refractory period. Now, making the tissue more refractory can be a good thing if you only make it a little bit more refractory. Why? Because, like, for example, atrial fibrillation, you've got these rapid, disorganized electrical activity going on. And in order to perpetuate atrial fibrillation, the cells have to be able to fire at rapid rates. If you prolong repolarization, you prolong refractoriness. You make the tissue more refractory, right? So that can be a good thing, as long as your QT interval doesn't get so long that you start to run the risk of torsade, okay? Because that can occur in long QT, and that's a whole nother discussion of what causes torsade. But let's sort of like try to get through all this. The 1B agents actually do affect depolarization, so they slow the phase 0, but only a little bit. They only are modest depressors of phase 0, and they don't affect, in fact, they actually shorten the action potential duration. So if I were to draw let's say if I were to draw quinidine, you would see a significant reduction in the slope and then the prolongation of the refractory period, the prolongation of the action potential duration. If I were to draw then lidocaine, you only have a slight reduction in slope, and actually your action potential tends to shorten. Okay, so lidocaine and mexiletine are mostly used to treat ventricular arrhythmias, like ventricular tachycardia, ventricular fibrillation acutely. They don't work that well. Sometimes they're used for PVCs, but they work best if combined with other things because they're sort of wishy-washy antiarrhythmic drugs. The class 1C agents are unique in that they are very powerful depressors of sodium channels. So these guys, flecainide and propafenone, markedly decrease sodium channels, and so they really suppress this phase 0, but the action potential duration does not change. Yes, indeed. So what you get is marked suppression of conduction velocity through the tissues. Now you can use these drugs to treat atrial arrhythmias like atrial fibrillation, atrial flutter, but they also have an effect on spontaneous depolarization. So they suppress ectopy because they're also suppressing sort of that sodium channel that results in spontaneous depolarization, that automaticity. So the 1C agents, when they were first marketed, were known as PVC killers, because if you give it to someone with a lot of PVCs, I mean, their Holter look beautiful. The problem is that they slow conduction so much that in somebody who had myocardial infarction, where you have, some tissue that is damaged in the left ventricle, that on the edges of that myocardial infarction, you might have regions with slowing that's already there, islets of normal cells surrounded by dead cells, and you've got sort of circuitous sort of reentry pathways. And when you slow that further, when you slow down these reentry circuits, they can become sustained. And that was actually demonstrated in the CAST study, which is in the late 1980s, when they used flecainide and propafenone and enconide, and they gave it to people after myocardial infarction to try to suppress PVCs and see if you can reduce sudden death, and actually the sudden death rate went up. So don't give 1C agents to patients with left ventricular dysfunction of any kind. I mean, that's just, a no-no because of the risk of proarrhythmia. That's the main reason why you have to find the ejection fraction. You have to assess patients for underlying heart disease, because flecainide and propafenone are extremely effective in suppressing ectopic arrhythmias. They suppress atrial flutter fibrillation. They do a good job with certain types of atrial tachycardia. They're great, but you have to only use them in patients with normal hearts. Okay, and in those patients, they work really well, and they have a very low risk of side effects and proarrhythmic effects and so forth. All right, so that's 1A agents. We don't use 1As much anymore. It's only very specific syndromes, arrhythmia syndromes, that we use them. And 1B, as I said, are mostly to treat ventricular arrhythmias. If somebody has VTAC and you put them on one drug, you can sometimes add mexiletine and get more effect. So, all right, let's move on before we use up this whole entire day. So let me go back to my layers and get rid of this, and we're going to turn on the rest. So the rest is relatively easy. So class 2 are beta blockers, and you have to remember that some beta blockers, the conventional beta blockers, block both beta in the heart and all, but they also block beta in the periphery. And remember, beta dilate the blood vessels, whereas alpha constrict. So when you get unopposed alpha, you get constriction of blood vessels in the periphery. That's why conventional beta blockers can make Raynaud's worse. They make your hands cold. And in fact, conventional beta blockers are not that effective in treating hypertension. Drugs like atenolol and metoprolol are not good to treat hypertension because they suppress LV function and they reduce cardiac output, but they constrict blood vessels. So what you really want to do is dilate them. So you can use instead alpha blocking beta blockers and vasodilating beta blockers like carvedilol, like labetalol, which is normodyne, and nebivolol, which is bistolic, are all much better to treat hypertension. But beta blockers basically block the beta sympathetic nervous system, and so that's going to have an effect on what part of the heart? The sinus node and the AV node, because that's where the autonomic influences affect mainly the sinus node and the AV node. There's not a lot of autonomic influence on the myocardium. Now, sometimes you'll have a focus in the myocardium that's very sensitive to adrenaline, and patients will get on a treadmill, do some exercise, and they'll start having rapid atrial tachycardia or atrial arrhythmias that are triggered by adrenaline. But most of the time, that's not the case. So when you give beta blockers to someone, for example, with atrial fibrillation, the effects are mainly on the AV node controlling the rate. They don't really suppress ectopic arrhythmias very well. I mean, you might get away with it, but they mainly to suppress AV conduction, slow the ventricular response down in patients with atrial arrhythmias. Okay, the class 3, oh wait, I got this wrong. How do you like that? I was so in a rush. So, sorry, this is class 4, which are the calcium blockers. Class 3 are the repolarization blockers. That was a brain fart, as they say. It's a good thing these are unrehearsed, right? So we'll talk about class 4 first, the calcium channel blockers. Verapamil and diltiazem are the only calcium blockers that have an effect on the cardiac conduction system, and mainly on the sinus node and the AV node. Again, calcium is the ion that moves into cells during depolarization of the sinus node and the AV node. They're known as AV nodal dependent tissues. And that's why calcium blockers are effective in slowing the ventricular response to atrial fibrillation, because they slow the AV node. However, keep in mind, at least in my personal experience, and I've proven this to my partners time and time again, verapamil works better. At least orally, verapamil is a much better agent to use to block the AV node in atrial arrhythmias. Diltiazem is available intravenously, and it's really easy to use, and you can titrate it, but oral diltiazem does not work very well. Certainly not as monotherapy. You often have to combine it with something else. Now, the other thing about verapamil is that you can have arrhythmias due to delayed after depolarizations. Now, what are delayed after depolarizations? Okay, so sometimes what happens is after the cell reaches its resting membrane potential, sodium can be released into the cytoplasm from the sarcoplasmic reticulum because of the misbehavior of some of those enzymes that are holding the sodium in. The ryanodine receptor, we talk about this in that advanced channelopathy lecture that I talk about, but it can cause a little secondary depolarization, something known as a delayed after depolarization, and this is a type of triggered activity. Now, delayed after depolarizations are actually a common cause, a common mechanism of certain atrial arrhythmias and even some ventricular arrhythmias. Certain PVCs, certain PACs, and even atrial tach, and some certain types of ventricular tachycardia, especially idiopathic ventricular tachycardia in the setting of a normal heart. It's very often due to this mechanism. So when you give verapamil, it suppresses these delayed after depolarizations and can treat certain forms of atrial tachycardia and even ventricular tachycardia. And it certainly can be helpful in people with ectopic beats that are due to calcium disturbances. Okay, so we'll keep that in mind as well. Now, finally, the class 3, which are the repolarizing agents, they primarily block repolarization. They block sodium channels, so they prolong the action potential duration. They make the tissue more refractory. They make the QT longer. Now, amiodarone is unique in that it actually blocks everything. It blocks sodium, blocks calcium, blocks beta, blocks potassium. So maybe that's why amiodarone is the most effective antiarrhythmic drug that we have. But it primarily blocks potassium, and that's why the QT can get longer. Dofetilide is Tachycardia, and that is a pure class 3 agent. It doesn't have any beta blocking activity like sotalol does. So sotalol is class 2 and 3. So sotalol is a beta blocker that also affects potassium channels and causes QT to get longer, makes the tissue more refractory, so it can be used in atrial arrhythmias. But dofetilide is a pure class 3 agent, and so it's good to use if you have someone sort of with tachybrady syndrome where you want to suppress the atrial arrhythmia, but you don't want to suppress the sinus node. So, but you have to be careful because it can make the QT very long in certain patients, and that's genetically determined. So you have to bring the patients into the hospital, start them, look at the QT, make sure they don't get torsade or anything like that. Ibutylate is a pure class 3 agent, but it's used acutely to convert atrial fibrillation. In the States, it's marketed with the brand name Corvert. And it's used to convert atrial fibrillation acutely. You give it as 1 milligram IV, and usually within 5 to 10 minutes, about 75% of people convert out of atrial fibrillation. All right, so that covers it, other than these other sort of like they don't fit into any neat category. Digoxin, turns out, blocks the sodium-potassium ATP-dependent pump in the cell membrane, and so it causes some sodium overload within the cell. Then the cell turns to secondary mechanisms to exchange sodium for calcium. So it results in more calcium in the cytoplasm available for contraction, which is perhaps the mechanism why digoxin improves contractility in patients with heart failure. I'm sure there are the physiologists out there who can explain it better. But it doesn't really work that well to control arrhythmias for 2 reasons. First of all, the effect on the AV node is due to increased vagal tone. So when the patient's asleep and their vagal tone is high, it has a profound effect, and it can cause very slow heart rates during sleep and long pauses. But if you put a patient on a treadmill and increase their sympathetic tone, the effects of digoxin essentially are negated. Digoxin does not decrease heart rates with exercise. So sympathetic nervous system basically overrides any effect digoxin has. So don't use digoxin for rate control as monotherapy because it generally will not work. Finally, ivabradine, which is the newest antiarrhythmic drug to be released, is primarily for slowing the sinus node down. It works on the funny channel, which is the funny current, that results in depolarization of the sinus node, so it slows the sinus rate down. And it's approved for treatment of heart failure when you have tachycardia. But you don't, but unfortunately, the one problem that I treat very often is postural tachycardia syndrome, or POTS, and other syndromes of inappropriate sinus tachycardia. And there, it's ideal, but unfortunately in the States, the insurance companies for the most part won't pay for it, so it becomes very expensive. And if you guys have any pharmacies in Europe or Canada or any place where I can reliably send my patients to get some Corvert, just let me know. Anyway, all right, so that's sort of all the antiarrhythmic drugs in a nutshell. But figuring out which one to pick, it has a lot to do with what the mechanism of the arrhythmia is. So in this case, you have these very frequent PACs here, PAC, aberrantly conducted PAC here. So there's so much atrial activity that's going on, and bursts and runs of rapid beats. I wouldn't use necessarily a beta blocker here. The first drug I might pick is verapamil. And the reason is, I'm just looking to see how long this has been, 40 minutes. Wow, it's a long one. The reason is that verapamil will often do 2 things. It suppresses some of the ectopy because it's perhaps due to calcium overload within the cells. and it also slows AV node conduction. So you won't get such rapid conduction of these bursts. So the first drug that I might pick in this particular patient is verapamil. Sometimes I'll combine a low dose of verapamil with a beta blocker, because I find that combining low doses of two different drugs that work by two different mechanisms will often get you better efficacy with less side effects. Because when you push a drug to higher doses, you'll get more side effects than you would with low dose. So that's why I try to combine low doses. If I use a little verapamil, then I'll add a little beta blocker, see what happens. Ultimately, when you have this type of ectopic focus that's firing like this, and even if you have periods of atrial fibrillation or atrial tachycardia or atrial flutter, assuming the patient has normal left ventricular function, then I might go with a class 1C agent like propafenone. Propafenone is different from flecainide because propafenone also blocks calcium channels and it also blocks beta receptors to some degree. So you get some conduction slowing down the AV node along with the suppression of the ectoby in the atrium. So that also you get two effects for the price of one. Flecainide perhaps does a better job and is better tolerated from a standpoint of non-cardiac side effects, but it doesn't affect AV node conduction at all. So you always have to combine something with flecainide, like verapamil or beta blockers. But be careful because flecainide is a negative inotrope and verapamil is also. So you just be careful combining them because you might wind up worsening heart failure. Of course, if the patient has poor left ventricular function, you'd never use flecainide, okay? So keep that in mind. So let's say that fails. And then you might be forced to use something like a class 3 agent, like sotalol may work, but in my experience, it's not the best drug to use. Amiodarone, of course, is the most effective drug, but if this is a young patient, then you might want to avoid using amiodarone because of the long-term side effects. And perhaps if this is incessant and if it's happening all the time, you might want to call an EP doc who could potentially find the focus and ablate it. But I think these ectopic foci are looking for a needle in a haystack, and sometimes there's multiple foci, and it gets to be a real horror show when you're trying to do ablations for this. So, so being familiar with which drugs to use in a situation like this is very helpful. So verapamil perhaps would be my first choice, then adding maybe a little beta blocker. Class 1C agents would be great. And if that doesn't work, you can try class 3 agent and see. But understanding the mechanism and figuring out that this is in fact an ectopic atrial focus that's firing and conducting rapidly, and then you have a million PACs, that's sort of how you have to approach this strip, and use your knowledge of the pharmacology to select the agent that would be most likely to be effective. Anyway, this was a very long presentation. Pharmacology is very complicated, and obviously I can't impart all of my wisdom in 45 minutes. So this is something that you have to kind of like explore and do some more reading. But this is there's not a lot written in ECG Academy for the pharmacology. So I just thought I would add this to our library, our archived resources for you guys. And so if there aren't any questions, there weren't a lot of questions because I was doing a lot of talking. So I hope this was helpful to you guys. I'm Jazz Winder. Thanks. Thanks for watching, putting up with me. I mean, there's a lot of people who sat through this. I mean, it can be boring, but it's so important because these are patients, and you're the one who's prescribing these drugs. And unless you know exactly how they work and which patients are best suited to which drugs, it gets to be very confusing, and you're not really doing the patient any favors. So with that, I'm going to wish you a happy Saturday, and I hope you have a great week, and hope to see you next week. Thanks.